Hello. So we've got a minute left. Just waiting for Unsuman to join me. See if I can add him. Just bear with me, guys. It's the first time I'm using this on live. Unsuman. There we go. Hi, Belinda. I've just tried to add him. I don't quite know. Oh, he's joined. Unsuman, join with your I don't know if I can enable to join. Send request. Let's see. Come on. Hi, Belinda. I'm just trying to get someone to join. I don't know what's going on. Zoe's joined. Let's have a look. This has not happened before, so I don't know why it's not letting me. And Simon, why can't you join? Does it say that you can request to join live or not? Let's have a look again. Bear with us, guys. We will start. Oh, here you go. Hi.
Hi.
How are you?
I'm fine, thank you. How are you then?
I'm good, thank you. Have you had a good day? And why can't you join? Does it say that you can request to join live or not? I don't know why that was something I said earlier. I don't know how that's happened. Maybe on your laptop or something. Again. Why is that happening?
I can hear you. Now it says send a request to be in. Okay.
Yeah.
Let me try again.
You're going to come off and then try again, is it? Okay, fair dues. Let's do that. So how's everybody? Oh, there we go. Can you hear me properly now? Is everything?
Yes.
Yes. Oh, thank you so much. Yeah, so thank you for joining us. We're doing this A to Z medical series, and we'll be doing this every month. We'll be talking all things medical, whether it's to do with health and well-being, any exams, training issues. And me and Ansuman, we've got quite a bit of experience in those areas. But there's some things that we don't know about, so it'd be good for us to, to learn about anything that you guys want us to talk about as well. Now, today we're talking about the RCA. And the RCA is the Recorded Consultation Assessment. It's a new GP exam that was introduced last year because of the pandemic. It used to be the CSA, where the trainees would have to go to the college and sit a proper simulated surgery. But now it's the RCA where you have to do your own recordings. I've not done that exam because I did the CSA, as someone knows. Before I start, I'll just introduce myself. I'm Zainab, I'm a GP, and that's it really. And I'm a mum of 3, so crazy times in my house at the moment. And do you want to introduce yourself, Ansuman?
Yes. So I'm a GP again, salaried GP, and I started last year after doing my RCA.
Yeah.
And that's it.
So we're going to talk about the RCA because a lot of questions. I've had a few trainees ring me actually and say, can you give us some advice about the RCA? And if it's an exam you haven't done, it's quite difficult to tell them about the technicality part of it. I mean, the consultations, we're quite used to that. I can advise them how to consult because the CSA is the same. You've got to do it in 10 minutes. But the whole process of RCA is a bit more complicated, isn't it? So can I ask you, what the first question is that I had got to ask you is how you felt when the CSA was cancelled, because you prepared for the CSA initially.
Yes, it was difficult and kind of came as a shock because I was supposed to do the March exam, and the exam went ahead in spite of COVID. I was supposed to go in the second week, but towards the end of the first week of the exam, the news came that, okay, it's indefinitely postponed. So it was
Wow.
kind of very uncertain times.
Mm.
Suddenly the exam got cancelled. No one had any news at all.
Mm.
And we were going towards our expected CCT date. And people were being given like straight away 6 months extension, and college will do something about it. We were hearing different things from different people.
Right.
So yes, very uncertain times at that
Yeah.
moment.
And I can imagine that must have been quite daunting, because then you're thinking, how am I, if you, when were you went to CCT? Was it August time, or would you have been, was it the September?
Yes, so I was my CCT date was second week of April.
Yeah.
So and I was uh, March exam. If I passed, so everything
Yeah.
was there, and the panel already did ARCP and said, okay, your results, when results come out, if it is a pass, it will straight away you will CCT and you are out. So
Wow.
so I was looking at that, and there was another personal thing also because of the exams. I was
Mm.
pushing back my visit to India.
Right, I
And
see.
I was thinking that once all these are done, I will be able to travel. So, so then it came as like a 6 months extension, and it was put in
Mm.
October.
Right, I
Uh,
see.
and there was nothing coming out like what is going to happen. So throughout the whole of April, there was nothing coming out.
Mm.
And some people were saying that these trainees should be allowed to CCT on the basis of their existing performance and portfolio. There was a
Right.
huge debate on it, because then those who were experienced, they were saying it would create two class of GPs, one who have done both the exams and one who have done only one exam. So,
Mm.
and we did not want that. We did not want to be looked at
Yeah.
like, oh, you had it easy. You did not need to do the exam. So it was, as I said, very uncertain times. And then it started changing towards the end of April. We
And
are
the
hearing,
information,
yeah.
just to ask, the information, were you getting contacted by email, or was it by your trainer? Who was giving you, or did you have to just physically visit the website or the RCGP and,
There were
every day?
there were no information at all.
Mm.
It was through our TPDs, who also had minimal information.
Mm.
And only thing was colleges trying to work out a solution,
Yeah.
but we do not know what that was going to be. So there
Mm.
was not at all any information. We were like, we did not know what to do. So
Yeah.
coming back to your first question, when we started our GP training, from that very first day, we were mentally and otherwise preparing for CSA.
Yeah.
And I can tell you, even throughout April, when it was very uncertain, I kept practicing for CSA, hoping that it will happen at some
Yeah.
point. So, towards the end of April, first we heard that there might be something, because the trainee representatives were in deep discussion with the RCGP bosses, and there was some GMC discussion also how it can be done. So then we were getting there was a big forum on I think it was on Telegram. Uh,
Okay.
Trainees all over UK, they were coming together discussing their worries, concerns, fears, expectations, what to do. So
Yeah.
and then it came out.
And how did you feel when you heard about the RCA? Like, did you how much information was there for you to, because you only had, how many days did you have to practice? Oh no, you had to film, sorry,
So
all your
yeah,
cases.
yes. So when first it came out, of course, it was very scary. A
Mm,
completely new exam, and no one knew anything about it, and none of the trainers did it because it was not there. So and the initially the information was very sketchy. We did
yeah,
not know, we did not understand actually what the college is looking for. But that was a dynamic process. So every 2, 3, 4 days or every week, things were changing. And that was even more difficult because more information were trickling in on the websites.
yeah,
And but it was like, say, 2 days ago, what I knew, today that changed. So like 30% changed and another 20% changed 3 days later. So it was very difficult time.
mm,
And then it came out like, okay, it would be recorded consultation. And then I think I attended a webinar um,
yeah.
by RCGP Midland faculty. And there was our very own Zirva was there,
Oh yeah.
and that gave us some ideas. But it was very college-like, very
Mm,
formal, and there were things that were being said as like very book-like.
mm,
So you were asking questions, but there were, rules, and those were being quoted. I mean, that's fine. Those are official webinars,
yeah,
but those helped. I attended 2 webinars, and the second webinar was end of May. So
yeah,
then we came to know that we will have to do the recording and submission through 14 Fish website, and that will be live from first week of June, and there would be effectively, when we counted the submission date and the first day of going live, it was only 16 clinic days.
wow.
So, and then you have to submit 13
Yeah,
consultations. So it was absolutely race against time. And uh, not a very good feeling when started. Did not think, did not believe that it could be done.
yeah,
16 days, 13 good consultations, and then there is this technology snag. Mm,
yeah,
uh, you know, a lot of calls would not be going through, so you miss good, supposedly good cases. So it was
yeah.
um, it was very early days and very confusing time.
Yeah, I can imagine. And you said that you had 16 days. Did you
Yeah,
record then every single day and then just
yeah,
record and every all
yeah,
day basically?
yeah.
Yeah.
So
Crazy.
I did CSA. So and you did CSA. You passed CSA. I did not pass CSA, so I was supposed to reseat in March. So you remember preparing, staying in a hotel, and morning you go to that building and you
Yeah.
are checked, and then you do cases and you come out.
Yeah.
I can tell you, for those 16 days, every day was like a CSA day. So
Yeah.
morning you go in and you hope there would be at least a couple of good cases that you can submit, and then with each case, each patient consultation not going as per your wish, you are frustrated, scared, nervous, confused, and you make mistake in the following consultation. So it's kind of 16 days of CSA.
That is crazy because I remember the pressure you feel when you do the CSA, isn't it? There's a
Yeah,
huge amount of pressure, that 13 cases. And I remember between each case, like walking up and down the room thinking, forget the last case, just get the next case done right. and feeling a bit worried of what's going to come through the door, even though you had a bit of an idea, but you know there's going to be a complex issue here that you need to extract from that patient. And also, the other thing you mentioned was the fact that you were quite nervous about it, but actually the exhaustion that must have gone with that, because when you film for, because some trainees now have a few months to prepare, and I think that's maybe a bit worse because you're constantly in exam mode, whereas when you do the CSA, you just do it on that afternoon or morning and then it's over and you can sort of relax until the results come in. But to do filming for 6 months, some people are saying, and that's quite hard.
Yeah, it has two sides. So when you have 16 days, in those 16 days, you might not get the cases you want. If you have a little more time, I'm not saying 6 months, but if you have kind of at least 6 weeks, then you have better chances of picking up, and also you will have more chances of listening back to your consultation. So I did not have time for that. So ideally, you have done like 4-5 recording. If you listen to those just once, you will be able to pick up areas where you will improve the next time. You don't need much help to do that. So with 16 days, it's like almost impossible. So.
And did you record straight from the 14 Fish website every single day on the computer, the work computer? You do it from there. So literally, you start your surgery, start recording on there, and then how did you select your cases? Did you sit down with your trainer, or how did you go through them and decide?
So we were always told by our CGP that the cases have to be challenging. Now, in a real life scenario, in CSA, the patients are professional actors, and they are optimized, and it is made sure that these cases are doable in 10 minutes.
Yeah.
Now, in real life, you don't have control
that is not
over
possible.
that. Absolutely not. So it was, so I actually involved the whole team. So my trainer, he was very clear that he did CSA. So now one thing, let me make very clear. So what they're doing, what they were looking at CSA was whether someone is competent to be an independent GP. The same thing they're looking for in RCA. So the basic thing is same, but the format is different. So my trainer did not tell me much about it, but he was there to discuss consultations. So I will come to that. Now, what I tried to do was I involved the team. So I was the first man in the surgery in the morning, and I was the last man out. I did that so that I can pick up cases, patients that I can do good consultation with. And I will go to the booking desk probably 2 or 3 times every hour, talk to them. I anyway shared very good relation with them, but I would tell them any new, I'm giving you an example, any new acid reflux or any new indigestion problem, put on my list. So those kind of things I would do. Any bleeding PR, first time booking, put on my list. Any elbow pain, first time, put on my list. So that kind of thing. And also I get them. So it helped me that my practice used to work from a central pool. So there would be all the patients booked in one list and they will pick up. So that helped me. I'd go the quickest, first man in. So, and I'll pick up.
So you don't have your own list in your surgery? Well, you didn't have your own list. Oh, right. Okay.
No. Interesting. And I would pick up Okay,
Mm.
these are the patients. And then I will go to the reception and give them a list of patients I chose. And I'd say, could you take some time out and tell the patient beforehand that I want to record these for my exam. So what happened would be when I contact them through 14 phase,
Mm.
when they hear that, oh, if you want it to be recorded, press this button and all, so they are not shocked. So
Yeah.
I used that help. So they helped me out with that. And one other thing, you asked about the trainer. What my trainer told me is, I don't care how many consultation you do in a day, whether it is 5 or 15. You just take your time. If you want to read about nice guidelines before
Mm.
you consult a patient, I don't mind. Look at the records, even if needed, for half an hour, and then do your consultation. So without that help, it would not have been possible to do these things.
Mm.
So
So they
that's
gave you
how.
that time basically to not be
Yes.
so pressured in a normal surgery, for example, 10 10 10 minutes. So they would give
No,
you a bit of time.
no, not
Yeah.
10 minutes. I always was on 15 minutes without any break. But they trusted me because
Mm.
towards the end of the day, I would anyway consult the number of patients I'm expected to. So I paid them back like that.
Yeah, that's
So
good.
I record my patients, and then there would be patients I'd pick up one after another and do enough. But there was never that pressure. No one
Mm.
came and told me like, oh, you have only done 10 consultation, you should have done 15. No one did that because my trainer always supported me in that.
And in terms of 14 fish consenting, although I know that there was a huge thing around that about consent. How do you do it on the 14 fish? Does it have an option to send them a message through that with, do you have to put their number in and then the text message gets sent to them? How does it work?
No, yes. So with the 14 fish, the consent process is very easy. So you put the patient's number in,
Okay.
and then when you press, there would be a code number, and then you call a number which is actually 14 fish number. The moment you call that number and press that code in,
Yeah.
then 14 fish would connect the patient, and 14 fish
Right.
would do the consent.
Mm.
So only if the patient gives consent, then it will be connected, and the recording will start. So if you do it through 14 fish, you don't need to, but I anyway just made sure that are you okay for me to go ahead with the recording? So I just did
Yeah.
that. It took me just 1 second, so no problem with that.
Yeah, I guess when you're actually doing it, it's easy to understand. Like, like I think when the RCA came out, there was a lot of anxiety around the actual technical side of it. How are we going to get consent? How does it work? But I guess you're right. Once you do it, the process is quite easy. And then coming on to the cases that you chose. So you only had 16 days. You're recording every single day, and then when you were choosing the case, I know you mentioned about your trainer not having so much of an input. Did you have more onus on the cases that you were going to submit?
Yes,
Because you
so
couldn't watch all the consultations, could he? You couldn't watch every
yeah,
single consultation you put on there.
no.
That would have been impossible.
So I will tell you the steps I followed. So first I decoded the exam in my head. So I understand this was my way of doing it, and all the trainees. I don't know whether many trainees are present here today, but trainees should probably follow the playbook that is on our CGP website. But
Yeah.
what I did was I thought about cases which are there in the practice list every day. So I did not look for overtly complicated cases. That is one thing. And then I tried to do a holistic approach, which was very useful for me. When
Mm.
I looked back, it was very useful. So it might be starting with a simple cough, but I never, if the list said chesty cough, I still gave it a try, whether I'd be able to do it as a consultation. And when I was doing the history and psychosocial, I would like to explore areas where there might be other factors, where the patient is concerned about, whether patient would be happy with a course of antibiotic, or patient is actually concerned about some cancer. My cough is not good, so that kind of thing. So I always work that out. So and then one thing we needed to remember with RCA is you do not you cannot go beyond 10 minutes. Now, can you just shut any patient down real life 10 minutes? No. So I thought, okay, as long as I finish history, diagnosis, and management within that 10 minutes, even if the conversation goes on, I don't mind. So I submitted cases which total length was even 14 minutes, but I finished one proper case within 10 minutes, and then the conversation went on to other things, and I still submitted that, because if the examiner stops the playback in 10 minutes, that's fine, because that's a
you've done your bit there.
Yes. So that's how I did that.
I mean, in the exam, I remember when I did the CSA, as soon as the 10-minute timer goes, the patient just goes and walks out of the room. It's kind of like, oh, you keep forgetting when you're doing the consultation that they're not real patients, they're just actors. But then when they walk out the room, when their expression changes, suddenly they're crying and they're suddenly like normal again. That's quite like, oh, you remember then you're in an exam. But when it comes to the actual selection of cases, you mentioned that obviously you chose not that complicated cases, you chose quite simple cases, but explored areas within those cases that made it made each one more interesting. What about the type of cases? So I know we got the option of doing face-to-face, telephone, video. Did you have a selection of those, or were they all a one type? Because I know you're allowed to do just one type, aren't you?
Yes, so our CGP playbook said that it can be any combination. It can be a combination of telephone, recording of face-to-face, or video calls. So any combination means you can submit 13 video recording, 13 face-to-face recording, or 13 telephone consultation, or any combination. So I started doing some video recording because it was during COVID and there were not much face-to-face happening. But then I realized that it is much better to do the telephone, because it's, of course, we cannot show our facial expressions and body language, but the verbal clues, the modulation in your voice, you can always show that you are a caring doctor and you are interested in the patient. And one good thing about this telephone consultation is also if you are putting on a speaker, and you can keep taking notes. Patient is not aware of that, so you don't forget. And so,
but the 14 I mean, when you're recording a telephone, how does that work then? Are they just video recording you on the telephone with the speaker on? No, how does it work?
It's audio recording.
It's audio recording. Oh, so there has an option for that, and then you just, okay.
They are doing that in their software.
Wow, okay. So they can't see you, they don't know what you look like or anything?
No. Okay. Now, one other thing about case selection, which I have not touched yet. So I decided that I will target a particular type of cases. One is I would definitely do a pediatric case, because pediatric case gives you option of doing a third-party consultation, and it shows your capability.
Absolutely, yeah, they're really good cases actually.
You can talk to a child, and also you will definitely talk to the parent. So that is one thing that I targeted. Second thing that I targeted was because of COVID, there were a lot of mental health cases coming in. And those are good cases if you can do well. So I was getting a lot of anxiety, stress, and depression. And I was trying to do them all right. So you can show a lot. Third type of cases I targeted was hospital discharge. So say a patient was in hospital for MI, there was PCI done, and the patient is back. Now, the first time you are talking, someone is talking to the patient with the discharge letter in hand. Those are consultations that can, you can show a lot of things. So,
and what
I
kind of
try to
things
do
did
that.
you show from them then? So what did you find with hospital discharges,
So,
particularly like?
yeah, so it is so checking how the patient is doing at the moment,
Yeah.
then checking how much the patient knows, whether the hospital was able to communicate properly, what happened to the patient and what management was done. And then also checking what the patient is expecting. So was the patient told that this is what to expect? Uh, is that meeting the real
That's really
expectation of
good.
the patient? And then always coming out of hospital, you can check with the patient's lifestyle and how patient is recovering.
Yeah.
So it's a lot of psychosocial mental health aspect and
Yeah.
medicine. So you can check like, oh, you are now on clopidogrel. Are you taking that? Do you know why you are taking it? So you are checking the medicines also. So you can show a lot.
Yeah, that's actually true. When you think about it, for a CSA case, even that would be quite a good one, isn't it? And
Yes,
so for RCA, but you're in that environment where you've got the discharge letter, there's so much information there that you can check with the
yeah,
patient. That's great.
yeah,
The other question is about briefing the patients. Did you
yeah,
ever? I know they get that consent thing through 14 Fish saying, "Oh,
yeah,
are you okay with it, the filming?" But
yeah.
what about briefing them? Say, can you speak about one problem and not like multiple issues?
Uh,
Did you have to
so
say that?
yes, so that is you cannot. So one thing, be very sure about, you cannot talk to the patient beforehand. If you by any chance spoken to the patient beforehand, like I'm giving you a quick call because I'm going to call you in 5 minutes time to record your consultation is ruined because immediately he called the patient and patient says hi again, and that shows that you have spoken to this patient, and that actually
I never
questions
thought
your.
of that because I know from one of the RCGP webinars they said that, oh, it's okay, you can prime the patient and just make sure that they only talk about one problem. But actually, you're right. Patients might not be aware that by them saying hi again, that they're actually,
Yes,
maybe causing a problem.
why I'm saying this is before asking my our receptionists to tell patient that this is going to be recorded,
Mm.
I first tried to do that on my own. That I'm Dr. Tikpati, I'm going to talk to you very soon, and for the purpose of exam, I'm going to record that. Is that okay with you? But then that actually, resulted in then I call and patient, instead of saying hi, says, hi, I'm Mr. Cooper. So hello again, doctor.
Oh my
And
God.
and and that actually ruins your flow of
Yeah, yeah,
consultation.
it does.
Even if you are not doing anything like dishonest. So
Mm.
then I stopped doing it and I started asking the staff to do it, so that this is the first time the patient is talking to me.
That's great. And then did you find that if they did have multiple problems, how did you tackle that, like that issue?
Yes. So
Yeah.
it's difficult. Again, you can prime your reception staff
Oh,
that
that's a good point. Yeah.
see, this is for exam. So is it okay if you talk about one problem only? And
Yeah.
if there is other things, we will give you further appointments. So it's kind of uh, giving incentive to patients. Okay, no worries. We'll talk one problem, but if there are others, then will do it for you. So I tried to tell that, but generally it was not a problem that patient wanted to talk about two problems. Problem was there are patients in real life
Yeah,
who are
yeah,
poor historians,
that's
talk
true.
less or talk a lot more, and there you struggle.
Yeah, that is true. Where you can't, you're trying to get one information out of them, one piece of information, and there's hardly any. They talk about something else, or
Yes.
and I guess CSA simulated patients don't do that. If
No.
you ask them a question, they tell you. They tell you the information that you ask them. Whereas real patients are a bit more, I guess, they just have their
Yeah.
own little way of saying things. So, but I think in a way it's good because it maybe made you better feel more comfortable. I think the CSA does make you feel more like, oh, it's an exam. But maybe the RCA actually in your own environment, own GP environment, maybe it's made you, do you think it's made you a better GP? Do you
Uh,
feel like is it better for you?
there is this thing that my trainer said. My trainer said that uh, once the telephone consultation started, not about the exam, because we started this because of COVID, and he actually thought that my consultation skills improved suddenly when I was doing telephone consultation. And his take was like I was under less pressure talking over the phone. And he's a fantastic trainer, so I think his observations are good. Uh, but um, comparing Rca and Csa, there are advantages and disadvantages. Now, you are talking about Csa patients and their actors, and they would not talk more or less, but they would be primed to only respond to certain clues. In real
Yeah,
life, real patients, it is much easier done. That's my realization, that you can get your information without using very specific phrases or terms, which does not happen in CSA. You have to use those particular phrases or
for your
terms.
questions and stuff. Yeah,
Yeah, so in that respect, CSA is much tougher. You don't
yeah,
say that, you don't get that. But in real life, patients are not simulated actors. So
yeah.
they even, you ask, so do you have any particular concerns? And in CSA, you use the term concern, and sometimes the simulators don't respond. But
Yeah,
here,
that's true. Yeah,
patient says, yes, I was a smoker, and my concern is you always hear about cancer, and you
yeah.
get your way. So that way I found that RCA is easier to, get clues from patients.
And that's interesting because some people might argue that the CSA patients, like cases, the simulator patients are easier because it's more.
No,
But actually, real patients, this is actually displaying that
yeah,
the real patients are
yeah.
better.
Problem
And
is,
go
sorry
on,
to interrupt. Problem is,
it's all right.
it's not easier, but the problem is there. These are the 13 cases you will do. You will be marked
Yeah,
on that. But in RCA, to decide on 13 good cases, so there might be 2-3 days on the trot where you don't get any good case at all. You don't get a good consultation at all. And that will drive you mad when you are like 16
yeah, I can
days
imagine. Yeah.
and 3 days gone without a single one. Yeah.
And then when you went through, how many did you upload in the end, if you don't mind me asking? How many
Yeah.
cases did you all
So
in
we
total?
had a discussion, me and my trainer. So he's a very busy man. So he's a partner. So it was not possible for him to, listen to all the
Hmm.
recording. So he had a way of doing it. So we agreed that if I listen to a consultation, some I will straight away reject. If I keep something on the case bank on 14th page, then I would rate it like 1 star, 2 star, 3 star. 3 would be the maximum.
Hmm.
And then when we sit together, then he will try to listen to the 2 and 3 stars. And
And then choose.
then we will debate like if he says, oh, this part, I don't like it. And then I will debate, why don't you like it? I did all the good things. And then we'll replay it and debate. And finally would agree with, okay, this good or not. So that's how we did. And then slowly we, reduced the short list. And we finally, you asked me about the number. I remember our submission date was Sunday midnight. So Saturday, we could not do anything. Friday was the last opportunity. So Saturday morning, we started, me and my trainer, at 9, and we finished at 6:15 without any lunch or anything, non-stop. We went through. So I had 2-star and 3-star, around 27 consultation there.
Okay, so good selection then, I suppose.
Yeah, because I tried to take out, and also I tried to get other GPs in the surgery involved, just to listen to a consultation overall and say, okay, you like it or not. So even though they have not done RCA, as a consultation, how they feel. So if that, agreed with my feeling, then I would keep those. So, you know what I mean? If I feel
I know what
something
you
is
mean,
good, and you also tell me, yes, I feel that is good, then I keep that. So that way. And then final was done by, in that day.
So what I'm getting from what you've said, Ansman, is quite interesting. They're not to choose cases that are too complicated either.
Yeah.
The good thing is that you don't have your own patient list, that you have a big list at your surgery that you pick and choose from as well. So you can have loads of acute and new cases. And if there's a simple case, trying to choose something, like extract something from there that will generate some sort of debate or something complicated. And I think that's quite interesting. And also the discharge, patients who've been discharged from hospital, that's really good. Pediatric cases. How many P's cases did you submit? Was it just the one, or?
No, I submitted 2 PEDS cases.
Okay.
1 hospital discharge. I think there was 1 mental health, 2 gastro cases. So one was a true equate colorectal referral, and the other one was, I think, reflux. There were 2 gynae cases. One was a true equate referral, and the other one was a missed true equate referral and some other issues. So there were 2 gynae cases. There was elderly care. So it was a different case. So someone with dry cough on Ramipril, and then while exploring, I found out that it is affecting her personal life because she is on her own and she relaxes by singing.
Oh, right. So it would have affected her.
And she could not do it because of the dry cough. So that was affecting. So
that's really good, isn't it? Because that's the kind of thing you would get in a CSA.
And that's what I meant by saying I went for the simple cases. Say, at the outset, it looked like a side effect of Ramipril, but then I found out, and she has a dog. She walks the dog, and she loves to sing. And then we went into her favorite singer, and then found out that she did not catch that. I'm not saying the doctor did not tell her, but she did not think she was told about the side effect of Ramipril. So there were a lot of things that came out from that.
That's crazy. So basically, the thing said dry cough, and then you basically found out all these things that potentially
on the list. It was not dry cough. It was meds review, and then
wow, okay, even more. Even more. When you see a meds review, you don't necessarily think that. You think generally they're quite simple. Say, oh yeah, I'm fine, I'm okay on this medicine. So that's mad. That is really good. Oh, well done. Congratulations on passing it as well and getting
almost
through
a
it.
year now. I did last June. So, around this time, I think 26th June or 27th June was my submission date. So
Yeah.
it's a year now. Mm.
And you know, that was the first batch that they, you know,
Yeah,
you did the first batch, and I think they said that people who hadn't passed it, doesn't count towards any of their, you know,
yes.
sit-ins or anything. So that was, I guess, in a way, it's good you've passed. It's done
No,
now. But do you think that, like,
no, Zainab, it's not
well,
good. It's still, it doesn't matter. College says that, okay, this would not count, but it
but
does not
it does count for
matter.
people who've passed it.
Yes, but if you fail it, then you know, then it will be counted now, and you have failed it once, and then you start groping like what would make me pass. So it was
Yeah,
still
yeah.
the same pressure.
It's still the same pressure. I totally get
Absolutely.
that. Totally get that. And you know, did you get any? You know, when you passed, did you have any trainees come up to you, ask you for any particular advice regarding the exam that you felt was quite good in terms of tips and things?
Um,
Like, what kind of things have people
yeah,
asked you?
I'm kind of I try to share this and always say that this was my way of doing it. So
Mm,
everyone can have their own way. I did join a VTS session where the TPDs asked me to speak to the trainees about my experience on RCA. So I did that, and then whenever someone asked me, mm, uh, so I told the trainee, okay, this is so. My message to them was always very simple, like you know, if you're confident, go for the simple cases, and if you explore properly, you will make the case good enough to be marked. No one would say, oh, this is a very simple case. So no case is simple.
yeah, yeah, absolutely.
So that's what I always say.
Yeah. And how are you feeling now that it's like looking back, and did you feel like it was a good thing that happened in the end, that it wasn't the
Yeah,
CSA that you in the
yeah,
end?
and then no, I did not have any control over that. Given a chance, if I were told that in June I would be able to do the CSA, I would take that.
Yeah.
I would not take RCA because
Mm.
I still feel this is, you know, relatively difficult because of the real life patients
Yeah.
and also overall lack of experience with RCA. Now, before I go to that, one thing, because this is going to be recorded and probably would be seen by
Yeah.
trainees. So there is there is another aspect that should be used smartly. That is, when someone is submitting the case on 14 fish, there are two parts. One is the heading, and other one is description, and that should be used smartly. That means that if I submit this elderly lady's case, so uh, I can, in the heading, I can say dry cough,
Yeah.
and in the description, I'd say dry cough from Ramipril affecting patients' quality of life. So that is telling the examiner what I'm going to show in this
Yeah.
consultation. So that's very important. I feel still probably not many trainees using that effectively. It can be used very effectively because examiner does not know what
Mm.
is this aspect, but you can take the examiner in your favor by pointing to that.
And on the RCGP website, it tells you obviously the two examiners, independent examiners, mark each case. So for just your RCA, 26 examiners, you know, marked individually the case. It's crazy, isn't it? How many examiners? And I think the GMC apparently are very impressed by that.
Yeah.
The RCA has been so people. There's so many examiners, and the marking scheme I think is similar to the CSA anyways. You know, with the
Yes.
data gathering, interpersonal
Yes.
skills, and
Management.
management as well. And they always say, oh, is a third of the marks, third of the marks. Actually, in the interpersonal skills is all the way through. I always think of it as a line all the way through the consultation. And then, you just got the little, data gathering
Yes.
management, at the, for 5 and 5, 50-50, basically. That's how I see it. 100% interpersonal skills for me, because I think if you're nice on the phone, especially with telephone consultations, you've got to really have that man over the phone to get them to give that information, isn't it?
Yes. Uh, you done CSA first attempt and very well, and you also helped trainees while you were still there.
Yeah.
I still remember you have a very good interpersonal skill, and I
Oh,
remember
thank
I
you.
practiced CSA stations with you more than once, and you pointed out where it should be. So I agree with that. Interpersonal skills, they run throughout. It does not matter whether you are doing data gathering, psychosocial, or you're doing management, safety netting. It runs through the whole of it.
Yeah,
So
absolutely.
yes,
Yeah.
uh, and over the telephone, it is all right to you have enough chances to show that you have good skills.
Yeah, and that's good if you're, for example, if you're a maternity, like if you're like you're pregnant, you can't be in the surgery, for example. Like last year, I had to
Yeah,
leave
yeah,
at 28 weeks and consult from home. So if I was doing the CSA, I would be able to, no, RCA, sorry, I would be able to do it, because if it was all telephone,
yes,
it would be fine, isn't it? So it's good that
yeah,
they've done that, and that they've allowed the same type of cases to go through, because they know some people are shielding and can't go to the surgery and see patients face to face, and that's
yeah.
good.
One one thing again about this telephone consultation, remote consultation, when someone is trying to do it for RCA, the trainee has to remember that if there is anything that the doctor, found difficult to pick up, patient said something but could not hear properly,
Yeah.
it's all right to ask. So I would say, like, mm, you told me that you have this cough for 5 days, and then um, towards the third day, you were starting to bring up flame, and it became from yellow to green.
Mm.
But after that, you said something that I did not catch up clearly. Would you be okay to repeat it? So it is fine. It shows that you listened properly, but you did not catch up something. So you are showing that.
Yeah.
So uh, and I made sure that in our telephone consultation, we did I did recall, so to show the examiner and the patient. So I said, okay, so far you have told me this.
Yeah.
Correct me if I'm wrong. And patient says, yes, you are right. And then I go on to, okay, now I want to ask you a few yes no questions. Is that all right with you?
And
So you
yeah.
recall and you show the examiner that I was listening very carefully. This patient is important to me.
But
Yes, go on.
sometimes I find
Yes,
that technique helps me,
yes,
because if I recall back the patient, while I'm
yeah,
recalling, I'm thinking of management, I'm thinking of differentials at that point, and you think,
yes,
it gives you that bit of space to think, okay, so you've mentioned this, and you're like, oh yes, it matches that,
yeah,
I'm going to do that. So it gives you that time, shows a patient that you're listening, shows the examiner you're listening, but also gives you a bit of space to make your own mind of what you're going to do
yeah,
next.
yeah,
That, yeah, it's a very good technique to recall,
yeah.
especially if you're stuck at one point. You think, actually, I need to just rewind back and
True,
rethink this.
true.
Yeah.
Yeah.
So yeah, that's brilliant.
Mm.
Well, do you have any sort of like, any questions for me even? I don't know. I'm just thinking,
Yeah.
because I've not done the RCA obviously,
Yeah.
but
I have a
and I
question.
respect, I can't, all these trainees that are going to be doing the RCA soon, and they said it's only going to be here for 6 months, 6 to 12 months, is now over 12 months now that
Yeah.
RCA has been in action. So you think, actually, is it here to stay?
I think so. Yes.
Yeah.
I think this is one thing. So if you already don't know, the trainees are paying less for this. Okay.
Okay.
So
How
yeah,
much less?
I think it is 300 less, 400 less.
Wow, okay, fair dues.
So
But why should
1,000
we even be
pounds.
paying that much? Because to be honest, if you think about it, we pay the college already so much for the CSA,
Yeah,
and we're going to their building, which is there. They're not renting it out; it's theirs, and we're paying so much
yeah,
money. And compared to other countries, we pay a lot of fees for our exams. So why is it only £300 less than like?
yeah. So, fee is less, and also what I believe is, in spite of this vaccination, because the virus is mutating, so I'm not thinking the first quarter of next year. Until that time, there would
Yeah,
be any consideration of changing the format to face again. And RCGP generally needs 6 months before changing it. So any change, if it is not done before December, it is
yeah,
not going to happen before next June. So RCA is here to stay. That's my take on it. I might be
yeah.
wrong, but that's what I think.
Mm,
Now, my question for you is, because generically both are the same, they're
mm,
looking at the same things,
yeah.
and you were just you aced it, the CSA. How would you have done?
How would I have done the
How would you
RCA?
have done it? Prepared yourself for RCA?
I mean, it's difficult to put myself in. I feel lucky that I'm not in that position to do that. But if I had to, I would probably do what you've done. Just start recording straight away. I think that's very important because I used to hate video consultations when I was doing GP training at the beginning. But eventually I started loving it, and my trainer was really, really good. He'd always go through them. And I started enjoying video consultations. It made me better in my CSA, I feel, because I picked up on any non-verbal cues or verbal cues that I was not getting right, that wouldn't look right in the CSA. So it did help me a lot. So yeah, number one, I would film straight away. And from what you've said as well, I would just pick as many cases that are quite simple and go, try and explore, because I'm sure you're right. Every case is interesting. It's just how much you're able to extract from the patient, basically.
Yeah.
And yeah, probably do that. Really, I'm not sure how else I would approach it. Probably just try and be myself when I'm doing the consultations, like not lose that interpersonal skills. Do my management and history taking, try and structure it out. But one thing I've learned is, as a GP, well, now working as a GP, I always have these ready-made files in my head. So if someone says they're coming in with a headache, I've got this like headache template in my head, so I know exactly what I'm going to be asking. So knowing, okay, this patient's going to be coming in with medication review, have a look at the medications, have my questions ready for what a med review should entail. If it's a hospital discharge, have your questions ready. That's what I would do. And then you can
Yes.
freestyle it as well.
Yes. So that's wonderful that you said, because that's how to approach any case. So pain in the pain abdomen. So you must have some differentials, common
Yeah,
differentials in your mind. Otherwise, after the general history, you cannot ask the closed questions.
yeah. It's true,
So
it's true. You can't go back and say, oh, by the way, where was your pain again?
yeah,
you've got, because once you have that template, you can build
yeah.
that picture up in your mind, and then, show that you're really thinking about what's going on. And it, I think I just love general practice, to be honest. I don't think I could have done anything else. I'm just glad that
The-
we've got this opportunity, isn't it, to make a difference in people's lives in the
I
way that we
agree.
do.
I agree.
Yeah,
If I'm given a chance again to go into any training, I'd again choose general practice, because I love to do medicine, and this is doing medicine in unselected cases. It's the most challenging and most fulfilling.
yeah,
Um,
absolutely.
yeah, but one good thing about being a GP is in exam you cannot go back, but in general practice, everyday practice as a GP, you can
Yeah.
always, no one is marking, you can always say, oh, by the way, I forgot to ask you this question.
Yeah, absolutely.
Can you? But of course, you cannot do that every consultation. It can happen probably once in a while,
Mm,
and that's why they want it speak and span in exams.
absolutely, yeah. Oh, well, we're coming up to an hour now.
Yeah.
Do you think that there's anything else that you would like to say about the RCA? Anything that you don't think we've covered? Or I know this was a
Mm,
sort of general Q&A about it. I know that things might change in the future, but the RCGP website's really good. It's got lots of information
yes.
now, so
That.
it's worth looking at
Yeah.
that. But this was your
Yes.
personal experience and how
Yes.
you tackled it. So it's been an interesting talk, really.
I yeah, I feel the trainees, the first thing they need to do is just grab everything there is on our CGP website about the exam. So that's very, very important. Just get the playbook in your head. That's
Yeah,
the first thing to do. And second thing is most important thing that I would suggest is be proactive. So pick up your cases, go to the GP. If you are not working from a central list, go to the GPs that are working in your surgery and say, okay, see, I'm looking for these two types of cases. If you have
yeah,
any, please let me know. And not once. Go to them again and again. Just make their life miserable until they give you. So
yeah,
that's how you pick up your cases, and then get the stuff on your side, because that's very important. You need all the support. Um, get your theoretical knowledge, up to date. So if you're going to do someone having this, abdominal pain, some diarrhea, just make sure that you are aware of the guidelines, so that you can say like, uh, you are 75 and you have this frequent loose stool, and there is some pain also. So
yeah,
I will need you to come here for an abdominal and back passage examination. And as per guideline, you will need to be referred to the hospital to be seen within 2 week wait. So because you have that in your head clearly, you can do that. So that's very important. So
yeah. I
these
think,
are all I would say. Don't hesitate to ask for help. Your trainers are trained to guide you to be a good GP.
yeah,
Not a single trainer I think have done RCA, but they're very good. They're going to make very good GPs, so they can point out, I think your consultation is probably lacking in this aspect, and work on that. So
yeah.
that's it.
And not to take it to heart, like, you want to improve yourself, and if someone else is saying this is not right, not feeling like, oh, why are they saying that? Just going with it and saying, right, okay, I
Yeah.
do need to improve it, and
Mm.
taking it positively. Oh, well, I don't know whether we should probably bring this to a close.
Yes.
And thank you so much. Well, we're going to do this on a monthly basis anyways. We're going to get to
Yes.
talk about other things. We're going to plan our
Yeah.
next meeting
Yes.
and then obviously put it on Instagram. But hopefully this will be really good, really
Yeah.
helpful for other people, other trainees that are going to be doing the RCA,
Yeah.
but also well, just join training so they know what's
Yeah.
coming through the door, coming in the future. But yeah, thank you for all those all the tips and that you've
Yeah.
given us today. That's great.
Yeah. It was
Oh,
it was lovely talking to you.
oh. Well, hopefully we'll be able to catch up face to
Yes.
face if
Yes.
one of these
Yeah.
days. Thank you so much, Ansuman. We'll
Yeah.
catch up soon.
Will do. Thanks,
Okay.
Shanab.
Shall I end this now? I don't know. I've
Okay.
not done this before. Let me see how I end
Yeah.
this. Thank you. Bye.
Bye. Bye.
Bye.
Bye.